morning, everybody, and welcome to the AIOS workshop for general ophthalmologists on diabetic macular edema. And we have a host of expert faculty who will be giving us a brief overview in whatever time it's allotted to them over the period of next 1.5 hours on various aspects of diabetic macular edema and proliferative diabetic retinopathy, including the investigations and management. So the first speaker of the day would be Dr. Dhanashree, and she would be talking on the brief overview of diabetic retinopathy. Dr. Dhanashree is a vitreoretinal consultant, senior vitreoretinal consultant from Shankar Nethralaya, Chennai. It's a pleasure to have her. Dr. Dhanashree.
Thank you, and I will start with sharing my screen. So at the outset, I would like to thank Novartis for giving me this opportunity, and thank you, Asmati, for the kind introduction. My name is Dr. Dhanashree Ratra, and I am a senior consultant in Australia. I would be talking to you about diabetic macular edema, the prevalence and pathogenesis, what the ophthalmologists need to know. So you know, last year, from about 1.5 years, last 1.5 years, the entire world has been gripped by this horrible pandemic of corona. But do you know that there is a more serious, a deadlier pandemic than the corona pandemic is happening right now and has been happening for quite a few years? And that is the pandemic of diabetes mellitus. Yes, diabetes mellitus has achieved epic proportions to be called a pandemic. Let us look at some statistics. Diabetes is the leading cause of death globally. It has the death by diabetes is much more than that by HIV or tuberculosis or other infectious diseases. And India has the dubious distinction of being the second highest number of diabetic patients. So if you look at the statistics published by the International Diabetes Federation Diabetes Atlas in 2019, there are about 463 million patients with diabetes living in the world. Out of these, 88 million are in Southeast Asia. And among these, 77 million are in India alone. So you can imagine the number of diabetics in India. And according to the prediction, there is bound to be a 74% increase in this number of diabetics. By which prediction, India is going to reach about 134 million diabetics in the next 25 years. So as the statistics stand today, 1 in every 6 diabetics in the world is an Indian. So the prevalence of diabetes all over the world varies, and India it's about 9 to 12%. And this is the state-wise prevalence of diabetes. You can see that Tamil Nadu and Kerala are at the highest prevalence of diabetes. So you know that diabetes affects all the organs in the body, but the eye is affected majorly. All the tissues in the eye are affected by diabetes, but the retina is the major problem because it carries a high risk of blindness. So you know that diabetic retinopathy develops in diabetic patients, and the diabetic retinopathy involves leakage of fluid in the retina with hemorrhages, exudates, and the swelling of retina in the macula, which is termed as macular edema. So the prevalence of diabetic retinopathy has been recorded by various studies, and the study done by Shankar Nethralaya by Rajiv has given the prevalence of retinopathy at 18%. And another study by Dr. Mohan's group has shown the prevalence to be about 20.8%. And a few studies have given the prevalence of diabetic macular edema, and it ranges from about say 4% to 14%. So let us look at the pathogenesis of diabetic retinopathy and DME, and why we should even bother about pathogenesis. That is because it can help us avoid the risk factors, and it can also help us identify the therapeutic targets. So this slide shows you the pathogenesis of DME, and as you can see, it is a busy slide and everything is interconnected with everything. So it's a little complex, but let me take you through it. So this is increased blood sugar in diabetes is metabolized through 4 major pathways. So you have the exosamin pathway, the advanced glycation end product pathway, the PKC pathway, and the polyol pathway. Now these pathways are augmented by increased blood pressure as well as dyslipidemia. There are various growth factors which also play a major role in this pathogenesis, as also the hormones such as steroids. Now, when the glucose is metabolized through these pathways, it leads to oxidative stress. And this oxidative stress leads to further apoptosis, of the retinal ganglion cells and the damage to retinal capillary endothelium. It also produces a lot of inflammatory factors, and these inflammatory factors lead to breakdown of blood retinal barrier and eventually formation of diabetic retinopathy. So again, you can see that the diabetic retinopathy also has an element of neural dysfunction, and this along with vascular permeability leads to diabetic retinopathy. Diabetic retinopathy goes through various stages such as mild non-proliferative diabetic retinopathy, moderate NPDR, severe NPDR, and proliferative diabetic retinopathy. Macular edema can be present with any stage of the diabetic retinopathy. And you all know that the changes involve microaneurysms to begin with, and later you have further capillary microangiopathy leading to intraretinal hemorrhages, venous bleeding, basement membrane thickening, and microvascular abnormalities. These eventually lead to neovascularization, retinal detachment, vitreous hemorrhage, and vision loss. There is also a separate inflammatory pathway that many people believe exists in diabetes. And this inflammatory pathway works through the ICAM molecules. These molecules, they lead to leukocyte adhesion to the retinal endothelium. The inflammatory mediators and the leukostasis eventually lead to endothelial cell junction breakdown, leukocyte formation, and pericyte loss. This leads to blood retinal barrier breakdown and eventually a macular edema due to transudation of fluid. So VEGF is the important factor among all these factors, which has been shown to play a major role in the development and progression of diabetic retinopathy as well as DME. It leads to a lot of structural and functional changes in various parts of the eye, and especially in the retina, it leads to breakdown of the capillaries, the blood retinal barrier breakdown, leakage from the capillaries, microaneurysm formation, and eventually neovascularization. So VEGF is an important therapeutic target because VEGF is driven by hyperglycemia, by hypoxia, and by various other growth factors. And there has been seen to be overexpression of VEGF in diabetes as well as in both diabetic retinopathy as well as in DME. And therefore, VEGF represents rational target for treatment of diabetic retinopathy as well as DME. So the VEGF mediated blood retinal barrier leads to accumulation of fluid. So you see this is a compact retina, a normal retina which shows you compact layers, but with the slow accumulation of the fluid, sometimes under the retina as well as the intraretinal fluid, you see thickening of the retina and swelling at the macular edema, causing a compromised vision. So you can have various types of macular edema. It can range from a simple non-center involving macular edema such as this, or it can have a focal macular edema with just one type of succinate involving the center, or you can have severe diffuse macular edema such as this with hard exudates deposited at the fovea. So there are different patterns. These different patterns can also be explained based on the pathogenesis. And if you have, say, diabetic metabolic dysfunction, which are again augmented by probably some genetic factors which we are yet unaware of, but this, if leads to vasodilatation alone, then it can lead to a slow progressive type of diabetic macular edema. If there is an endothelial cell loss and hyperpermeability with the loss of blood retinal barrier, then it leads to wet leaky type of diabetic macular edema. And if you have capillary thrombi formation with capillary closure, then it leads to an ischemic type of macular edema. Here you see that the foveal avascular zone is enlarged and a capillary non-perfusion area right next to the fovea. In the OCT, it can show you some diffuse retinal thickening or cystoid macular changes or a neurosensory detachment type of macular edema. The risk factors for development of macular edema are basically long duration of diabetes along with high blood pressure, increased HbA1c, that is poorly controlled diabetes, and also some risk exists if there is a high cholesterol level. It also depends on the type of diabetes. It is more commonly seen in type 1 diabetes, less common in insulin required, and little bit even less common in non-insulin dependent diabetes. And it also depends on the severity of diabetic retinopathy, as I told you. Obviously, with very severe diabetic retinopathy, you would have higher risk of diabetic macular edema. Now, diabetic retinopathy and nephropathy goes hand in hand, that we all know. But it also, diabetic macular edema also is associated with further risk of comorbidities. So it is seen that diabetic patients with DME have a higher rate of both acute MI as well as cerebrovascular accident. So to conclude, I would say that diabetes is a complex disease. Prevalence of diabetes and diabetic retinopathy is on the rise. Diabetic macular edema can occur at any stage of the disease. There are multiple pathways which are involved in the pathogenesis of DME, as well as there are various risk factors. And understanding of these can help prevent vision loss and can help identify newer molecules for treatment. Thank you for your kind attention.
Thank you, Dhanashri, for an excellent overview of diabetic retinopathy. And without much ado, I'll go on to the next talk. I will be delivering the next talk on the interpretation of FFA and OCT in PDR and diabetic macular edema. So I will share my slides. Are my slides visible? Are my slides visible?
Yes.
Yes.
I'll just go on to slideshow. Tell me if it is visible.
Yes.
Okay. So it's the interpretation of FFA and OCT in PDR and DME. And I thank the All India Ophthalmic Society for giving us the opportunity to present our experience in this. So first is fundus fluorescein angiography, in which involves injection of a dye called sodium fluorescein into the antecubital vein, and this is the fundus camera, and serial photographs of the passage of the fluorescein in the retinal circulation is done. These are the more advanced fundus cameras which we have. And this is how the fundus fluorescein angiogram of a normal retina looks like. You have the arteries filling up, and then the veins, you can see the laminar flow. For a beginner, if the laminar flow is seen, that is the vein, and this is the central retina macula, and you generally have a foveal avascular zone surrounding the central retina. And these are a few fluorescein angiograms which I will show. Since the time is only 20 minutes, so I will be showing only few pictures. This is a color photograph of a new vessel, but if you do the angiogram, you get much more information. You see that the new vessel has started leaking because they have leaky walls. At the same time, you can see these black areas in between the big vessels. That is, all the entire capillaries have been obliterated. So these are the capillary non-perfusion areas you can see even here, which basically has resulted in an outpouring of VEGF, which has led to the formation of this new blood vessels. So fluorescein angiography gives you a much better understanding of the extent of ischemia in such conditions wherein even the new vessel is already obvious in proliferative diabetic retinopathy. And in macular edema also, it tells us about the type of macular edema. This is a diffuse type of macular edema in which no clear-cut microaneurysms are made out, a little bit of capillary non-perfusion areas here. Whereas here in this, you can make out these small dots, which are the microaneurysms, which are focal leaking, focal leaks. So you can aim your laser on these spots. So fluorescein angiogram gives us an idea how to treat and manage and prognosticate all types of diabetic retinopathy. And this is a proliferative diabetic retinopathy, and you can see that the macula doesn't seem to be involved that much, and clinically it seems quite obvious. So in this case, fluorescein angiogram is almost unrevealing because it doesn't give us any new information because of the excessive leakage from the new vessels on the disc and elsewhere. So in such cases, the general ophthalmologist and us also, it's better to avoid asking for an angiogram in which, things are so clinically obvious. Whereas in conditions like this, you see that there's a huge preretinal hemorrhage here. Not much of things going on here, maybe a little bit of hard exudates, but you can't make out anything unusual here. And this is a red-free photograph. And so we really need to know whether we are looking at proliferative diabetic retinopathy. So we'll do the angiogram. You can make out the new vessels here, and also so many new vessels which were not clinically obvious have been highlighted here. So the clinician basically needs to use the judgment, his or her judgment, in ordering the test for fluorescein angiography because it's an invasive procedure. And this is also, obviously, this is a proliferative diabetic retinopathy with a new vessel and few microaneurysms and all that. But, it's a good montage, but we would also like to know the extent of peripheral ischemia. So when we do the angiogram, we find that cases here and all where clinically new vessels were not obvious, you can make out new vessels, and these are most probably irmas. So you know the extent of the disease and you can treat effectively by laser. And this is one such condition, another condition where fluorescein angiography is helpful. This is a patient with nephropathy, diabetic nephropathy, and you see vision is only 3/60, and you have a waxy pallor of the macula, and we really don't know what's going on. Probably the vessels look a little occluded, many cottonwool spots. When you do the angiogram, the macular ischemia is totally evident. You see the parafoveal capillary non-perfusion areas. So this is the reason why the patient has a poor visual acuity. In fact, macular ischemia has been suggested to be a marker of diabetic retinopathy. And of course, there are several shortcomings of FFA apart from the fact that it's an invasive procedure. We have come to understand that there are 4 capillary plexuses in the retina and in the posterior pole especially, and the importance of a deep capillary plexus at the level of inner nuclear layer is increasingly being understood. Whereas fluorescein angiography cannot delineate the deep capillary plexus and cannot differentiate the deep capillary from the superficial capillary plexuses. And also all the microaneurysms cannot be delineated. And the foveal avascular zone size, which is important for prognostication and to rule out macular ischemia, is not clearly possible many of the time because there's a lot of leakage which confounds the picture. And a very important fact of diabetic macular edema, which is serous macular detachment or subretinal fluid, cannot be delineated by fluorescein angiography, apart from the fact that it's an invasive procedure. These are the shortcomings of FFA in DME. And based on all this, we have moved on to OCT, optical coherence tomography, which has become one of the most valuable additions in the armamentarium of a medical retina specialist. It's a non-invasive, non-contact transpupillary imaging, and it's akin to B-scan ultrasonography, in which cross-sectional images of the retina are produced using the optical backscattering of the light, and all the layers of the retina, and nowadays even the choroid, can be beautifully delineated within a matter of seconds. And the resolution can go up to as much as 1 micron. And it uses near infrared light. It's totally non-invasive Michelson type interferometer. And we had the initial time domain OCT, which measured the time of flight of light. And now we have spectral domain, which measures the wavelengths of back reflected light. And now we've moved on to sweat source OCT also. So this is the Fourier domain or the spectral domain OCT. You can delineate more vessels with higher number of scans in a point of time, and it's a 50 to 1,000 times faster than the time domain OCT. And with the patients with media opacities, high myopes, pseudophakic, small pupils, it's much better picturization when compared to time domain. And now we have moved on to swept source also, which images the choroid and the sclera very well, because we have come to understand that including diabetic retinopathy, the choroid plays a very important role in the pathogenesis, and we have a better penetration through vitreous hemorrhage, dense cataract, etc. So how do we interpret OCT? We have qualitative analysis wherein we look at the morphology, we look at the contour, presence of abnormal areas, we look at the reflectivity, whether it's hyporeflective, hyperreflective, whether there's any shadowing. Then we look at the quantitative analysis, thickness and the volumetry, and also do a 3D analysis in certain specialized situations. Basically, the colors of OCT are all false colors, and bright colors like white and red suggest highly reflective structures, whereas dark colors like black and blue, especially when there's just fluid, that is shown as low reflectivity, and intermediate reflectivity is shown as green. This is almost similar to a corneal topography, as you can see. These are high reflective, and this is low reflective, and the green is middle reflective. And normal foveal profile, we are expected to see a good foveal depression. And this is a preretinal area, this is the epiretinal area, intraretinal and subretinal areas. And the preretinal profile also is important in diabetic macular edema. We should look for tiny dots which can signify vitreous hemorrhage, or an epiretinal membrane, or a preretinal membrane, or a vitreomacular traction. All these things we should look out in the preretinal area. As you can see, this is a systemic macular edema in a diabetic patient, but there's vitreomacular traction as well. So the treatment changes. We need to do vitrectomy to treat this condition. And this is a diabetic macular edema, and this is a taut posterior hyaloid and an epiretinal membrane, and this is systemic macular edema. So these patients may need a possible surgical removal later in case they don't respond to intravitreal injections. And there are several protocols that we follow. We have radial lines, raster lines. We do a macular thickness map. And generally, the radial and the high definition line scans we employ quite a lot. And we generally tend to avoid interpreting the scan in false colors. We go to the black and white, or sometimes white on black mode also, to understand the pathology better. And in tomography and diabetic retinopathy, the OCT, we can talk about diabetic maculopathy, wherein which we can delineate diabetic macular edema or DME, or diabetic macular ischemia or DMI. And peripheral retinopathy also, OCT can talk about, give us an idea about capillary non-perfusion, neovascularization, and tractional detachments, how to manage, etc. I will be showing a few illustrative examples. And initially, DME used to be classified as clinically significant macular edema and non-CSME in the ETDRS era. Now we have moved on. OCT has been a game changer. We classify DME as center-involving and non-center involving DME. And based on the OCT morphology, we classify it to a spongy swelling, cystoid macular edema, serous detachment, and taut posterior hyaloid membrane. This is a diffuse sponge-like swelling of retina. These are the cystoid spaces with the walls. And here is a clear-cut cystoid macular edema with lot of septate. And this is another entity which can be imaged only by OCT. This is a serous macular detachment, SMG, or subretinal fluid, SRF. It basically indicates chronicity, and that the RP pump, this is the RP layer, and you see that it's quite thin. It's basically sick. It means that it's sick. It's got a guarded visual prognosis, and usually patients have nephropathy or uncontrolled hypertension or anemia or long-standing diabetic macular edema. So by looking at the OCT itself, you can prognosticate what else the patient can have. And subretinal fluid basically, however, is suggested to have a protective role based on RESTORE, RISE and RIGHT studies, and it predicts a better visual acuity gain and the fewer injections over a period of time. And it also probably indicates that the patients with SRF and diabetic macular edema may respond better to anti-VEGF injections. And quantitative 3D maps also, if it is red, that means it's definitely the thickness is increased when compared to yellow or green or blue. Blue, in which it means the retina is thinned out. So there are certain scenarios in which OCT obviously obviates the need for FFA. You don't need an FFA. This is a diabetic patient with chronic renal failure, vision only 2/60. Some hard X-rays are there, but why is the vision so poor? You do an OCT, you can't do an angiography because the nephrologist is saying no. So you see that there's so much of inner foveolar thinning with deep retinal exudates. So this patient's visual acuity is unlikely to improve much. So no intervention. And in tractional detachments also, OCT gives us an idea about the extent of TRD, helps us in the treatment. For example, this patient, little bit of traction here, you can see, but there's a cystoid macular edema. The foveola actually seems little okay. So you just manage this patient with anti-VEGF injections. Whereas this patient, if you see a 57-year-old gentleman, lot of pre-retinal hemorrhage, you don't know whether to just do laser, a little bit of fibrosis here, or go ahead and operate. And this is the final picture, but let me tell you how we reached there. This is the OCT. We just directed the OCT to the supratemporal quadrant TRD complex, and you can see that there's a huge TRD complex pulling the retina. And the foveola, you see, is so thinned out with so much of cystoid spaces. So if we don't operate much, there is a risk of operate fast. There is a risk of de-roofing and an inner lamellar hole formation. So we did a careful vitrectomy, did not do an ILM peel, and the patient was how we saw that in the previous slide. And nowadays, we have a lot of excitement about OCT biomarkers in DME. And why do we need that? Because we have found out that central retinal thickness is not a very good indicator of how the patient is going to progress. And there's only a modest correlation of the visual acuity with the DME. And OCT biomarkers can mark the presence, pathophysiology, and prognosis of DME. And as you know, these are the 10 layers of the retina, and all are beautifully illustrated in the OCT. And I'll just take a little time in this. This is the nerve fiber. This is the internal limiting brain, the nerve fiber layer. This dark area is the ganglion cell layer. These two white lines for the dark area in between are what are important for us. And I'll be telling you why. This is the inner plexiform layer, and this is the inner nuclear layer, and this is the outer plexiform layer. This actually represents the metabolic circuitry of the inner retina. So the health of this is very important. And when you look at the OCT, if you see these two white lines with the black area, that means inner retina is relatively fine. And in the outer retina, we have the external limiting membrane, and you have two brightly reflective zones. This is the inner high reflective zone, which previously was thought to be the junction between the inner and outer segment of the photoreceptors. Now we think that it is most probably the ellipsoid layer. And this is the outer segment of the photoreceptors, this hyperreflective zone. And this is actually the interdigitation zone between the outer segment of photoreceptors and the RP. And this is the retinal pigment epithelium layer. And this is the choroid, and this is the Bruch's membrane. And this is, of course, the outer nuclear layer. And if you see the outer retina in greater detail, the inner segment of the photoreceptors has got the outer ellipsoid and the inner myoid. And this is what is seen in greater detail, especially in swept source OCT. You can make out the ellipsoid zone very well. And this is the RP Brooks membrane. And this line on top of the RP is the interdigitation zone. And this external limiting membrane. So this external limiting membrane and ellipsoid zone's integrity are very important. And nowadays we have started looking at these areas in greater detail in diabetic macular edema. So these are all the different markers that we look at: the intraretinal cyst, the ELM integrity, the drill, hyperreflective dots. Now, let me just talk about hyperreflective dots, better seen on white on dark OCT angiograms. You see these dots, they can be present all over in the deep as well as the inner retina. And how do you distinguish from hard exudates? Hard exudates are generally larger and they have some shadowing, especially if they are quite large. This is a typical hard exudates, whereas these are hyper-reflective dots, which are small and they don't have much of a shadowing. And there's another important entity in OCT called drill, which is basically the horizontal extent in microns, wherein you can't distinguish the boundaries between the plexiform layers and all that. And within the central 1 millimeter wide area, drill is looked for. For example, this CME looks more extensive, but you can see that this area has got drill, whereas here you can make out the two whites with the black in between. So this patient will generally do well when there is no drill, disorganization of inner retinal layers, whereas this patient doesn't do so well following treatment. And this is one such patient. Despite a huge cyst, you can see that here there's not much of drill, and this patient does quite well with flattening of the cyst following intravitreal anti-VEGF injections. So also loss of parallelism by a specialized software of the outer retina, as well as we also look at the presence of epiretinal membrane in which the whole treatment of the macular edema changes. This is before surgery and this is after surgery with a well-restored foveal contour. And also as I told you, we look at the external limiting membrane and ellipsoid zone at DME. And we'll also look for outer retinal tubulations. In contrast to cystoid phases, the border of outer retinal tubulations, which suggest chronicity and a poor prognosis, are hyperreflective. So we look at that also. And this is a very good article. You can go up and look at it. It's an overview of the OCT biomarkers in DME and also cumulative risk factors, like for this patient with a thin outer retina, huge cysts, drill, hyperreflective dots here and there, and an epiretinal membrane. This patient is not going to do well at all. And also we have started looking at the choroid, diabetic choroidopathy, choroidal vascular density and volume, and choroidal vascularity index, which is ratio of luminal area to the choroidal area, again done by a specialized software that is supposed to be decreased in diabetic patients even without retinopathy. Just briefly about OCT angiography, which detects the motion of scattering particles like red blood cells, and it's the latest. The newest SD OCT systems and swept source OCT systems talk about OCTA. The most exciting thing in diabetic retinopathy of optical coherence tomography angiography is that we are able to look at the superficial and deep capillary plexuses. And if you see, this is an angiogram, whereas this is an OCT angiogram, gives us a much better information. And you can demonstrate microaneurysms in all these findings, just as in an FFA. Of course, it's rapid and non-invasive when compared to an FFA, but doesn't talk about the blood retinal barrier states. You can't get an idea about the hot disk, and we don't have wide field OCTA now, so peripheral CNP areas cannot be delineated. And even in patients without diabetic retinopathy, OCTA has showed a statistically increased FAZ enlargement. It has been suggested to be used as a screening tool. We also tried in some of our patients. This is a patient without diabetic retinopathy. As you can see in the OCT, where the FAZ was enlarged. And you can also measure the size of the FAZ by angioanalytics. And this is the superficial plexus and the deep plexus. In fact, deep plexus ischemia is supposed to be a poorer prognostic factor in DME. And as I said, by angioanalytics, we can measure the extent of the FAZ involvement. And the FAZ size is also correlated to the peripheral ischemia, and it is suggested that an irregular FAZ predicts significant peripheral ischemia and disease severity. And this is a very good paper by Lee et al. In Ophthalmology 2016, wherein they say that deep capillary plexus, the loss of microaneurysms, actually corresponds to the loss of the discontinuity in the synaptic portion of the outer plexiform layer. In fact, the deep capillary plexus is situated at the inner border of the outer border of the inner nuclear layer. So you see that this patient has got the continuity of the outer plexiform layer and not much of a DCP distortion, did very well following anti-VEGF, whereas this patient had discontinuity of the inner plexiform, of the outer plexiform layer, and a DCP which was much widely involved. So this patient did not do so well after anti-VEGF injections. And why? There are several reasons why the DCP loss translates to anti-VEGF responsiveness. And PDR also, OCTA talks about several type of new vessels wherein we can image the MVTs beautifully like this and also document their regression. And there are several advances also, like the VISTA algorithm and the quantitative OCT and the wide field OCTA. So thank you very much for your patient hearing, and we will have I'm sure, a very good discussion to follow. And I will stop sharing my slides. And now it's my pleasure to invite Dr. Rajiv Raman, Senior Vitreoretinal Surgeon from Shankar Netralaya, and he will be talking about patient journey and workup in diabetic macular edema. Dr. Rajiv.
Sir, you're muted.
So thanks, Dr. Vasumati. Next couple of minutes, I'll be sharing some thoughts on what exactly is the patient journey, a patient of diabetic macular edema, and what is the initial workup in diabetic macular edema. So as Dr. Dhanshri rightly mentioned, that DME is one of the most common cause of visual impairment in people with diabetes. So in our SN Dreams, a population-based study, we did show that 10% people in rural area, 15% in urban area, and probably about 20% in metro urban have diabetes. And if you look at diabetic retinopathy, 10% in rural and about 18% in urban people, diabetics have diabetic retinopathy. And 5%, irrespective whether they are rural or urban, will have diabetic macular edema. And if you look at the visual impairment, 40% of the DME will have some form of visual impairment. And this was a visual analog scale, a study which was done with people with diabetes, and they were asked what is the principal fear they have. And if you look at majority, the most common fear person has is blindness. So it is important as far as patient is concerned. And diabetic macular edema affects the working age group. So it's nearly, the mean age of a patient is nearly 50 years of age at the time of diagnosis. And we also know that majority of type 2 diabetes are the patients between 40 to 60 years. That means this is the productive age group, the working age group, and DME is a leading cause of vision loss in a working age group. In contrast to cataract, which usually you see after retirement. Another fact which compounds the problem is that it requires a long-term management. It's not like one-shot treatment. The definition, what Wiki says about patient journey, is the sequence of events a patient follows from the point of entry into a health system and then continued interaction with it. So the journey begins from the diagnosis of diabetes. This was a very beautiful study which was done, Time to Do More for Diabetes. It was a survey which was done for both physicians and patients. Physicians who were busy physicians, more than 100 patients they were seeing a month. And the patients who were diagnosed to have type 2 diabetes. And at the time of diagnosis, they did this study, and a very good sample across many countries, including India. And they tried asking them to recollect the topics which were addressed at the time of diagnosis. So you can see the physician did tell that they need a lifestyle change, the disease and its cause, the drug treatment, and even the microvascular complications. But when the same thing was asked to patient, that means how patient perceived this information, only about 70% they really felt that the doctor told them about lifestyle change, and retinopathy is much worse. And the situation is not that simple. Of these 50%, only half of them actually went ahead following the advice of the physician. As far as diet is concerned and about exercise, hardly 40%. And if you see the reason they said that it's difficult to do exercise because of my present weight and other things, and I find it difficult to make changes in the life. So what it means is that whatever is conveyed also is not actually taken into account when a patient sees. And microvascular complications, though the physician, nearly 90% of them spoke about it, told about the importance, but what patient recollected, only half of them, they felt that something about eye and other parts involvement was told. And even in these patients, about 60% of them, they felt that they know that it affects the eye, but it seemed to be a very remote problem. It's not that important. However, if you look at what they are worried about, as far as all other complications, as I had mentioned before, is the loss of sight or the retinopathy. So that's the journey which they start with. And journey is often beyond vision. It's not only the eye. And this was one of our study. We did what is called as a cost utility evaluation. Basically, it is how many years of life they are ready to give for a perfect vision. And for diabetic retinopathy, they are ready to forego nearly 30 to 40 years of their life. That means that is so much important for the patient. We have heard this, that diabetes itself is nowadays considered as a cardiac event because it is associated with high risk of cardiovascular events, hypertension, cardiovascular accidents, cerebrovascular accidents, and that's the reason it is a leading cause of death worldwide. The patient with DME again has many, there are evidences that it's not only diabetes alone, but if a person has diabetic macular edema, all the complication risk is much higher as compared to those without diabetic macular edema. So this was a study where they tried looking at what is the risk of acute myocardial infarction or a cerebrovascular accident. And you can see nearly more than 2.5 times more risk of a patient who has diabetic macular edema as compared to patient who has diabetes with no diabetic retinopathy. So they are prone. So the journey is not only the eye, they have many other events during this journey, which is important. This is another important thing, that it's when they have on MRI, the white matter lesions, the risk is much more, especially for a cerebrovascular event or a stroke. So a patient with retinopathy and on MRI having cerebral white matter lesions, the risk is nearly 4 times more of developing stroke. So that again suggests that it is not the eye alone, but throughout the body, the features happen. Now, I will take you across to a journey of a patient with diabetic macular edema. So what I spoke till now was the time before diabetic retinopathy. No, he has a life before he developed the feature, and that's a time where he has neglect of health, wrong beliefs, denial of the disease, poor compliance, and then usually the diagnosis is by chance because screening is not a very routine process in our country, and he thinks that's a bad luck. And again there is a factor of denial, though we tell them that it's your diabetes, but he immediately says my diabetes is very well controlled. Then comes the shock and fear of first injection, and that's a fear which all our DME patients have, and that actually is much more than the fear of a decline of vision if he doesn't treat it. That's something we need to address. And then he comes into the assembly line of injections. So that is a time this is another phase. He feels that there are a lot of waiting, lot of appointment, not much care of sense. That's the feeling which a patient gets. And then he gets dazed and confused because there is uncertainty which is there. He's very uncertain about the treatment schedule. If he goes, whether the injection will be given or not, what is a break in the injection thing, what is progression of disease. Sometimes doctor says there is swelling, sometimes he says now it is flat. So that's a confused stage. And even that stage, there is a caregiver burnout. Many times we know some patients, the moment we see, we just get a little bugged up that, oh, I've been injecting that, especially the non-responders. So this is the phase, a journey which a patient of DME undergoes. And then there are two ways it can go. Either he takes control, there is good systemic control, good compliance, follow-up, his vision improves, quality of life improves, or he progresses, the stage of retinopathy progresses, and at some stage the vision is not improving, he takes help of a low vision aid, and the course is down course. So this is the journey of a patient of diabetic macular edema. Coming to the second part of my talk on workup of a patient of a diabetic macular edema, I'll be talking about initial workup, a very short, already Vasumati has covered beautifully the role of imaging, and OCT, I'll just touch shortly on that too. So history taking is a very important step in a whenever you are dealing with diabetic macular edema, and there are a lot of clues which you get. The duration of diabetes, we know, is one of the most important risk factor for both diabetic macular edema and diabetic retinopathy as such. Medications which he is on, insulin, oral hypoglycemic drugs, antihypertensive, lipid-lowering drugs. Is there any change in medication? Many times when a patients are transferred from a oral hypoglycemic to insulin, there is a sudden control or sudden lowering of blood sugar, which aggravates the diabetic retinopathy. Sometimes they may develop diabetic macular edema. Systemic history is important because they all have bearing on diabetic macular edema too, the renal profile, cardiovascular events, systemic hypertension, lipids, and pregnancy also. There are certain drugs which cause macular edema, and especially in a case of diabetic macular edema, if he is on these drugs, you can see more of edema, and sometimes they may be the sole cause of macular edema. You may be injecting them, which may have no effect till you stop these drugs. Thiazolidinediones, the glutathiones, are a drug. Besides that, there are many others like fingolimod, which is a anti-cancer drug, tamoxifen. Important is niacin, prostaglandin analogs. All these cause macular edema, so you should take a history on these. Get a detail of any recent ocular surgery which has been done. You need to differentiate between a pseudophakic macular edema and a diabetic macular edema. Any details of previous laser and what was the indication of these lasers. A detailed history of previous injections. Many times when we get patient already having many intravitreal injections which have been given, it's very important to take a detailed history. Which was the drug used? Was there any subjective improvement after the initial injections? Number of injections he had taken, and important, I even note down the dates so that I calculate what was his compliance for the treatment. This was a 54-year-old gentleman, diabetic for 7 years, reasonably good controlled diabetes. Right eye had no diabetic retinopathy, left eye had moderate non-proliferative diabetic retinopathy with macular edema. He had received a couple of intravitreal anti-VEGF injections. And after that also you can see one cyst in the parafoveal inner ring. He had the history of use of glutazones, and we just stopped that. We never injected at this visit, and you can see the macular edema totally went off. There are evidence now that it's not only thiazolidinedione, but if they are also on insulin, definitely the risk, the hazard ratio of developing macular edema is much higher. Coming to imaging in diabetic macular edema, when you do imaging, you tend to do imaging prior to initiation of the therapy to delineate the stage of diabetic macular edema and diabetic retinopathy. And then you repeat as needed in the event of a non-responsiveness or during the monitoring of this patient on a long term. OCT is the mainstay of monitoring and diagnosis. However, we have seen there is a role more and more of OCT-A now coming up, and wide field angiogram. There's also a role of ultra wide field photography. I'll be just showing a couple of examples of it. So this is a wide field angiogram, which already I think Vasumati also showed. We can pick up these subtle NVs, which are sometimes missed on clinical evaluation. A person who is non-response to anti-VEGF, sometimes we can make out the leaking microaneurysms and see if they are amenable to laser also, or that also gives you idea of what would be the next line of therapy. Clarus, no commercial interest, but this is a wide field, very high resolution image where you can even make out these subtle NVs. Sometimes you may need not do a fundus fluorescein angiogram just to diagnose these NVEs. Sometimes you also get a wide field photography done to know the adequacy of panretinal photocoagulation, whether there are any skip areas you would like to treat if the new vessels are not regressing. OCT, you want to classify whether it's a vasogenic, where you have these cystic spaces and the microaneurysms which are leaking, or you don't have many of these features, non-vasogenic type of edema, and more important, which you can never pick up on anything, the tractional element, except for OCT. You want to know which type of edema you are dealing with. Role of OCT is there. Just before we start with role, how you diagnose diabetic macular edema. Is it OCT or a clinical examination or a retinal photograph? Yes, definitely by a good biomicroskeletal biomicroscopy and a photograph, we can know about diabetic macular edema, but OCT is an important feature. And this was a beautiful study where they did both the evaluation. And what is alarming, that patients who had diabetic macular edema on OCT, just on fundus photography, nearly a third of them were not found to have DME. They were not diagnosed as DME, even if the DME caused visual impairment. So it's important, all these patients. So the rule is that if you have anything more than moderate NPDR, and clinically, even if you are not suspecting, good idea to get a baseline OCT done in these patients so that you don't miss. When to do? So baseline to assess DME on monthly visits and in a patient who has poor response or a non-response to anti-VEGF. What parameters you want to look? You want to look at central retinal thickness, the central subfield thickness to be more accurate to monitor your treatment. And qualitatively, you try to look for markers of vision gain and markers of response. There are a lot of markers, but two of them already it has been shown, the disorganization of the inner retinal layers. This is when you are unable to segment the inner layers, is one of the markers for visual gain. Another marker is the ELM disruption or loss of ISOS layers, which gives us, these two are a very consistent markers. If you find this, unlikely, even after resolution of macular edema, the vision may not improve. The same thing, parallelism already has been spoken about. The markers of response for anti-VEGF, good response, so you have a higher thickness, you get a better response. You have hard exudates, they tend to resolve better. Neurosensory detachment is a good marker, so it resolves very quickly. The poor markers with anti-VEGF is presence of epiretinal membrane, hyperreflective dots, which are thought to be more related to inflammation. And on a OCTA, if you find an enlarged deep capillary plexus, definitely that's something which again is a poor indicator response to anti-VEGF. For steroids also, neurosensory detachment is a good marker. Hyperreflective dots and hard exudates are again presence of these. We think that it works better. This is all based on the evidences. ELM integrity and ellipsoid zone integrity, they are responsible. If they are compromised, the response of the steroids is usually low. So to conclude, the key elements in a successful management of diabetic macular edema is you must understand the patient journey. And as I told, the patient journey is not the journey for the eye alone. There are many other factors which he has during his journey of diabetes, and a comprehensive initial workup which can give a good successful management of diabetic macular edema. Thank you very much. I'll be happy to take any questions.
Thank you, Dr. Rajiv, for a very nice overview of the patient journey. And it's actually the retinologist journey as well. And we go hand in hand. And now it's my pleasure to invite Dr. Guru Prasad, a doyen in the field of vitreoretinal disorders, to talk about the management of proliferative diabetic retinopathy and diabetic macular edema. Dr. Guru Prasad.
I'm not able to hear any.
Your screen is not seen, sir.
Now? No?
You can double click to enter the full screen mode.
No, I'm on share mode only.
Now I can see. Now
yeah, it is seen now.
It is seen now, right? Okay.
Yeah.
So this is my title slide. Is it visible?
Yes.
Thank you very much. Thanks for this opportunity. Thanks to AIOS for getting this, giving us this slot through the Novartis. And I'm very happy that I'm in the midst of doyens in the field of retina, like Dr. Rajiv Raman and Vasumati and Dr. Dhanashree Ratra. I've been allotted the topic of management of PDR and DME, and I hope I'll do justice to it. Here I go. So PDR is the presence of neovascularization of the optic nerve head or retina, or the presence of preretinal or vitreous hemorrhage, or NVI. Any of these three if present is PDR. So this slide is already shown about a couple of times by the previous speakers. I will not go into the details except to say that VEGF plays an important role in the pathogenesis of PDR and DME both. According to the ETDRS and DRS guidelines, when you have a picture like this, a proliferative diabetic retinopathy with either a neovascularization or preretinal hemorrhage, which is actually clubbed under the high-risk characteristic PDR, immediate treatment with PRP laser is advisable. So this is how we do pan-retinal photocoagulation or PRP. Prior to 2008, this is what we used to do in divided sessions with the single spot laser, starting inferiorly and marking a boundary temporal to the macula, and then go and treat the rest of the retina, following the nasal retina, then the superior retina, and finally coming to the untreated temporal part. And after all this, if there is persistent neovascularization either on the disc or on in the retina elsewhere, a tightening of the laser was done with treatment of the extreme periphery and also filling up the skip areas. And with that, there used to be resolution of the neovascularization. Today, we have the Pascal laser and the multispot laser from different companies, and this allows a faster treatment with similar effect and less collateral damage due to the short exposure but high power that is employed in this technology. And this is what we end up with, a beautifully ablated retina, which can be done in one session, but I think a couple of sessions is better to top it up 2 weeks or 1 month later with the second session of the far periphery. So if there's a preretinal hemorrhage, which usually we see after about a couple of months, we call the patient after about 2 months after the laser, depending on the condition, of course, this follow-up period is highly variable. So if we have this kind of picture after a good laser treatment, then what we have to do is to employ good glycemic control, do a fill-in PRP to the areas that have been skipped, and then follow up closely. And this is an example of an unstable PDR. Patient has undergone laser elsewhere, and you can see that a large area of the retina has not been lasered. And this extensive skip area has led to subhyaloid hemorrhage, and this is a patient who will need surgery. This is an example of further progress of diabetic retinopathy with the causation of fibrovascular proliferation causing traction retinal detachment involving almost the entire posterior pole extending up to the laser scars in the periphery. And such patients usually need surgery. And these are some examples of this. Incidentally, is The same patient, both the eyes being affected by proliferative diabetic retinopathy with extensive membranes in the right eye and subhyaloid hemorrhage in the left eye, although not affecting the macular region. He was lasered then in the left eye. In the right eye, he was given anti-VEGF surgery and anti-VEGF injection, followed by a week later by surgery. And this is the picture post-operative, 3 weeks later. I just want to show this this very severe stage of PDR, because the PR was inaccurate in this. The disc was not at all seen. There was thick fibrous tissue. There was sclerosis of all the vessels. But with meticulous surgery, this was the picture, and the patient recovered fairly good vision. And this is the picture 4 weeks post surgery under oil. The patient has 3/36 vision. So I think it is good to operate on every possible case where there is some visual potential. If there is PL, although the PR may be inaccurate, you must reattach every retinal detachment with some hope of recovering vision because of the advancements in microvascular or microincision vitreous surgery in the present day. Another example of a PDR with a macular hole, severe fibrous tissue proliferation causing traction, and the traction has resulted in a hole also. And this is the post-operative picture. First post-operative day and this 2-week post-operative picture are showing excellent results, and the visual recovery is 3/36. This is 1 year later. You can see that there is extreme retinal thinning. I'm sorry, this is of another patient. So there is retinal thinning and drill, and because of which the vision has just recovered up to 1/36. Now, coming to complications of laser, we have talked about laser, we have talked about surgery. Laser has its complications, but we have to weigh the risks and benefits. There is field constriction and night vision problem. Patients usually complain of difficulty in driving at night and reading. Transient macular edema immediately following the laser. There is serous retinal and choroidal detachment, sometimes to the extent of causing severe choroidal detachment, anterior rotation of the angle of the antechamber, causing acute angle closure glaucoma as well. But this is extremely rare. If you do it in divided sessions, or if you do it with the Pascal or multi-spot laser, it really doesn't occur. Now, that is what brings us to protocol S. drcr.net, they found that ranibizumab was non-inferior to laser PRP. The incidence of DME and the severity of DME was reduced in PDR when it was treated with ranibizumab. Eyes treated with ranibizumab were less likely to need vitrectomy, and peripheral field preservation was better with ranibizumab than with PRP. But it was invasive, needed repeated injections, and there was also the risk of infection, which could be disastrous to the patient. And most importantly, the cost. This cost was extremely prohibitive, making this option not non-feasible for all, especially in the Indian scenario. So, but then anti-VEGF does have a place in the management of PDR, even in the Indian context. My own indications for ranibizumab in PDR would be, of course, as a preoperative adjunct in surgery for PDR. This was even before the protocol S was published. When laser is not possible or has been inadequate due to a small pupil, you have a PDR, you're not able to see the peripheral retina and laser the peripheral retina, you can definitely do the injection treatment. New preretinal hemorrhage or mild vitreous hemorrhage in an already adequately treated eye is something that is definitely an indication for an injection. And if it is in a patient whom you want to do laser, patient is unwilling, or if the patient is high risk for surgery, for example, patient may be having renal problems, they may be having cardiac problems, he may not be given clearance by the physician, patient has a mild vitreous hemorrhage causing some floaters in an adequately lasered eye, you can top it up with treatment with ranibizumab. Coming to DME, diabetic maculopathy is a broader term, and DME is, I think, a narrower term. DME is any edema within 2 disc diameters from the foveal center, whereas diabetic maculopathy encompasses both DME and the edema caused by traction and the anatomical changes in the macula that occur due to traction. This is my favorite slide, which shows how damage to the capillaries by loss of pericytes can result in leakage from the damaged capillaries and microaneurysms, resulting in swelling of the retina and exudate formation within the intraretinal layers. So this is my algorithm for diabetic macular edema. On an OCT, if you find that it is attractional, there is a tractional component, then surgery is the answer, and we already covered this part. But for example, this is the traction component which of a diabetic macular edema which warrants surgery. If it is non-tractional, then you have the focal and diffuse type, and in the focal you have the center involving and non-center involving. And if it is non-center involving, laser is an option, although less and less people are doing laser. I also restrict myself to laser, that too with the subthreshold micropulse laser, for patients who are fed up with taking injections, although it doesn't really work very well in my hands. And of course, we have pharmacotherapy for all others. So we have covered laser and surgery. So what we're left with is pharmacotherapy with either anti-VEGF agents which have been there since 2006 and steroids which have been there since 2014. But it is not just VEGF. Retinal disease has multifactorial pathophysiology. There is in any retinal disease there is a component of vascular leakage, neovascularization, and inflammation as well. And we can see that even in diabetic macular edema, there is a substantial component of inflammation. In today's armamentarium, we have ranibizumab, we have bevacizumab, aflibercept, the VEGF trap, and dexamethasone intravitreal implantation, which can be used effectively in the treatment of diabetic macular edema. Let us see some examples. So this is an example of a 50-year-old male, diabetic since 6 years, loss of vision since 2 months, and both eyes severe NPTR with diabetic macular edema, with vision grossly reduced in the left eye to just 1/60. So this is the picture of the OCT. You can see that both eyes ranibizumab was given to this patient with cystoid spaces. Give me a minute. I will just try to minimize my taskbar, which is blocking the view. Okay. Can you see? Hello, Dr. Vasumati, is it visible?
Yes, it is seen.
Yes, sir.
It is seen.
Right. Thanks. One moment. Yeah. So this patient had 6/18 in the right eye to begin with and 3/16 in the left eye, and you can see that after ranibizumab there was a slight improvement in the right eye, but very good improvement in the left eye, which actually appeared to be more involved. And after 2 months, the patients usually don't come when we usually tell them to come in our scenario here. So the patient came after 2 months, and in both eyes, ranibizumab was repeated, and you can see that at 6 weeks later, that this also was not at 4 weeks, but at 6 weeks. And at 6 weeks, there was an improvement in the vision from 6/12 to 6/9 in the right eye, in spite of the OCT remaining the same. But you can see that in the left eye, the foveal center was normal on the previous visit, also normal in the next visit, but there was slight recurrence of cystoid macular edema, but the vision had improved. Vision had improved from 6/18 to 6/9. So there is visual improvement. And if you can see from the first and second IR image, you can see that there's a lot of exudation here. And
Dr. Guru Prasad, we are not, your slides are not moving.
Not moving.
Or is it only in my screen?
One moment.
It is not moving.
Not moving. Okay, just give me.
It has gone on to the first slide.
No, you just make it full screen. Yeah.
One moment. Let me go.
And go back to that slide, please.
Yeah, one moment. Yeah, I'm so sorry. Yeah.
Yes.
You can see now.
Make it full screen, sir.
Yeah, one moment. Slideshow. Is it okay now?
Yes.
Yes.
Okay, I'm sorry. So what I want you to see here is that the hard oxidates that had accumulated in the foveal center after the first injection actually disappeared after the second injection, and I mean not totally disappeared, but definitely got less after the second injection, and there's a lot of visual improvement after 2 injections of ranibizumab. Coming to my second example, you can see that this is a patient of severe NPDR in both the eyes with macular edema. The macular edema is not so obvious on the clinical picture, but here you can see that on the OCT, there is a gross cystoid macular edema with subfoveal fluid as well. This patient, we thought that we'll go by the protocol T and give aflibercept to this patient. And it was given to both the eyes. And you can see that within a month, when the patient came back for follow-up, the patient's vision had improved from 660 to 612 in the right eye and 636 and 618 from 636 in the left eye. So this was a case of patient treated with aflibercept the first time, but the patient could not started developing macular edema again, and there was a slight drop in vision in terms of letters in the fourth and fifth lines respectively, and therefore the patient opted for ranibizumab this time because of the cost factor with aflibercept. And the patient came back only 2 months later with persisting macular edema. And you can see that the macular edema has actually increased on the OCT as well. And at this point of time, DEX implant was given to both the eyes. And this is the picture 6 weeks after DEX implantation. You can see that from 612, there is improvement to 6.9 and 6.9 in the left eye as well. So one must consider patient compliance and also the initial visual acuity. This is just the lesson that we learned from this particular patient, or what we should be doing as a result of the outcome of this particular patient, that I must say is that this we must consider patient compliance and also the initial visual acuity when we're treating with pharmacotherapy. But that is not the end of the story. This patient came back only 6 months later because of COVID fever, and there was lockdown. She was staying about 400 kilometers away, and post unlock she came, and at this point of time there was florid NVI in both the eyes. So patient vision had dropped to 2/60 in the right eye and 6/36 only in the left eye. We had a couple of teleconsultations, but I think that has limitations, and we cannot depend much on teleconsultation. And the questions I wanted to be answered in this particular patient was, should DEX be avoided in severe NPDR because of the possibility of the VEGF being not controlled well, and could that have caused the NVI? And does anti-VEGF also cause more ischemia, and could that have resulted in, can that result in NVI? These are the two questions probably we can take up in the discussion. And did this NVI have anything to do with COVID fever? So this is something that we have been listening to in the last couple of days during this All India Ophthalmic Conference in various halls where diabetic retinopathy is being discussed. COVID and NVI is something that we can discuss. Another patient with severe hard exudates at the accumulation of hard exudates perifoveally in the left eye, and mild diabetic macular edema in the right eye with corresponding vision. You can see that. And this is the OCT picture. All I want you to see here is that the final visual acuity is good from 618 and 660 to 612 and 636 over a period of 1.5 years. So I'm not going to the details of this story, but this patient had repeated injections, although not at the time when we told him to take, but he was coming, though not regularly. He was coming and taking the injections, and the final visual acuity was good. So I think persisting with the treatment helps. And you can see here in the right hand side, the hard exudates that were there in the beginning had resolved after 1.5 years. So this is a case of a rare case of hard exudates being totally resolved, almost gone here in the bottom right slide here. So how do we manage recalcitrant non-responding macular edema? We know that we have already gone through this, the OCT biomarkers. I think I'll not repeat it. It's enough to say that hyperreflective spots, drill, EZ, disruption and subretinal fluid or all subfoveal fluid are all indicators of inflammatory drive, and therefore might do better with steroids. And ultra wide field angiography in DME is something that we would like to definitely discuss at this point of time. Then the ischemic index is more than 45%. This incidentally is a study done by our own Indian origin Americans, Ravi Patel and Sinu Hariprasad, who said that more than 45% ischemic index, meaning the area of the retina which is ischemic in the periphery, if that is ablated with a targeted retinal photocoagulation or a TRP instead of a PRP, that can result in stoppage of the ischemic drive and the cytokine release and the VEGF drive, and ultimately reduce retinal vascular leakage and diabetic macular edema in recalcitrant cases. One interesting study that I came across is the quantitative approach to predict differential effects of anti-VEGF treatment on diffuse and focal leakage in patients with DME. And they found that by semi-automated segmentation on FFA, that leakage outside leakage outside 117 microns from the microaneurysm was considered as diffuse edema, and that within 117 microns was considered as focal edema. And they found that anti-VEGF treatment resulted in preferential reduction of diffuse edema and not so much reduction of focal edema. And therefore, focal edema might probably be more responsive to other modalities of treatment, especially steroids. So in summary, I must say that we have to identify the type of DME in the management of diabetic macular edema as those of tractional origin and those of non-tractional origin. Consider the baseline visual acuity while choosing the drug. For example, the protocol T told us that low visual acuity is patients do better with aflibercept. Look for OCT biomarkers in non-responders. Stage the background retinopathy to choose the pharmacotherapy. This again we can discuss during the discussion time. And be aware that diabetic macular edema could be a peripheral disease, the same thing that I was talking about, ultra-wide field angiography and targeted retinal laser photocoagulation. And have a low threshold for switching drugs. Thank you very much for your patient listening, and we'll be happy to have some discussion on this. Stop share.
Yeah, our technical team, can you please allow Dr. Gopal Pillai? He's waiting in the lobby. Technical team, Mayank,
Yes, sir. Yes, sir. Yes, sir. Yes, I will.
Thank you, Dr. Guru Prasad,
AV team?
for a very nice lecture on treatment and of proliferative diabetic retinopathy and diabetic macular edema. We are waiting for Dr. Gopal Pillai to join us. And hi, Gopal, at last. And it's our pleasure to listen to you on intravitreal injections, tips and tricks. Dr. Gopal.
Thank you very much. I have also been waiting to be with you for quite some time now. So let me first of all tell that there are no tips and tricks. Okay, there is plain, safe intravitreal injection, and that is all. There are no tricks. There's only safe intravitreal injections. So what are the types of intravitreal delivery? Apart from the usual intravitreal injections, you can have devices which can have microsphere devices, nanoparticles, all these things are going to come in. And the majority of injections that we are going to do is the anti-VEGF, and there is a small share of antibiotics, steroids, gas, etc., which we inject as well. The indications for the anti-VEGF is actually ever enlarging, which had the AMD, the PCV, the choroidal neovascular membranes, now DME, CRVO, BRVO, now including PDR also, then radiation maculopathy, tumors, coats, etc. So first of all, let us look at how to perform an intravitreal therapy. Once you decided that you are going to give an intravitreal injection, there are different people who would take the patient to a safe room in the OPD to inject, but generally we prefer it to be in the operation theater itself, just because it is more cleaner and less movement occurs within the theater. So if you have such a room elsewhere with equal sterility, that is also all right. But anyway, you have to make sure that you are performing all the aseptic precautions and preoperative precautions. Just like what are the precautions that anybody would do for a cataract surgery, the same precautions we have to do for intravitreal injections as well. So we need an informed consent written for intravitreal therapy regarding the drug, regarding which drug, regarding the possible complications, regarding the futility of treatment, regarding repeat injections which may be needed. All this may need to be highlighted. And if you are using an off-label drug, that also needs to be highlighted. The pupil is best dilated, and we have to prepare the intravitreal injection of 1 cc syringe and a topical anesthetic agent or peribulbar anesthesia. Generally, we would prefer a topical anesthetic agent, but use 5 to 10% povidone to clean the eyelids and to irrigate the ocular surface and conjunctival sac. So we may need to actually use betadine to cleanse the whole thing. Put in a few drops of povidone in here and make it stay there for about 3 minutes, because betadine liberates the active povidone, which actually the iodo-4, which actually takes about 3 minutes to act. So that is a very important thing, preoperative prophylaxis. Please douche the conjunctival cul-de-sac as well. Now it is up to preparation of the drug. So the drug will be coming. Right now we have pre-filled syringes, but mostly we have to load from the syringe. And before withdrawal, the outer part of the rubber stop needs to be cleaned perfectly with disinfectant. And then we have that 1 ml syringe onto which we have the 18 gauge, the filter needle, which is a long needle. That is actually, that will cause, filter all the impurities out. So usually what we have to do is, usually whenever we take an injection, we, put the vial upside down and take it out. But here you have to actually keep the vial vertical and put in the needle inside the vial, and then tilt the vial so that the beveled part is, the bevel is very, very mild. So that the beveled part will be taking onto the corner wherein you take in the whole drug. Usually the drug is much more than what is actually necessary. That is because we will require to remove the air out. So withdraw all the liquid, keeping the vial in upright position, and then ensure that the plunger rod is drawn sufficiently back. Because now if you don't draw it as well, there may be a lot of drug remaining in the vial and you may actually waste it. And leave that filter needle with the vial and take out your syringe, and then attach a 26 or preferably a 30 gauge needle, which is a 1/2 inch needle, onto the syringe. So we should make sure that there is no air bubble, because you see between the needle tip and the hub, there is a dead space of about 0.05 ml. And then this is the hub, which also has about 0.05 ml. And then here we have about 0.05 ml. So that is the total content. So totally, even if your whole needle and the hub and the syringe contains 0.1 ml, probably only 0.05 ml will go into the eye. So we have to make sure that there is no air bubble by pushing the air out. And then, don't wipe, or the needle should never touch anywhere. The only place the needle should touch is on the conjunctiva and sclera. So then we use about 3.5 or 4 millimeter from the limbus. You can use a calipers to measure that, and then inject it towards the center of the globe and slowly inject. 0.05 ml of syringe needs to be injected. And when you take out, you can use a swab stick or you can use a forceps to close to prevent reflux. And in case if you feel that the pressures are high, or if the optic nerve is very labile, and if you fear that the pressures may actually damage the optic nerve, probably you can consider doing a paracentesis as well. This is a small video. You can see the video. This is the, yeah. So make sure that the needle does not touch the lid margin also. The lid margin, even though it is very clear, now as you see, I'm touching that particular thing. So here you can see there is adequate distance between the lid margin and this, and the direction towards the center of the globe. Slowly inject, make sure that you can see the needle on the back of the lens, and that is all. Okay, you can use a swab stick to prevent any regress also. So here we are probably doing a paracentesis as well. You can see that we are doing a paracentesis. Without the hub, you can just put in the needle. Without the siphon of the syringe, you can just take out. Adequate aqueous will come out, about 0.05 ml will come out. And then you can measure. This is a pseudophakic, so we'll measure about 3.5 millimeter. And then you will inject. And you can see the needle very clearly. Yeah. Okay, so this is the make sure that the lid lashes or the lid margin does not touch the needle. That is very important. I think that would be that. And then let us move in. Yeah, pharmacokinetics, drug spreads through the vitreous as in a free solution. And then a mathematical model, which can use a fixed second law of diffusion, assumes vitreous body in a cylinder with three major pathways. One is aqueous elimination, retrochoroid scleral elimination, and lens drainage membrane. Drug decay rate is higher in a diseased eye than in normal eye. What are the possible complications? One is compromised protection to the other eye, compromised protection to the other organs, and local complications like endophthalmitis, vitreous hemorrhage, retinal detachment, PVD induction, retinal necrosis. The most important one is the endophthalmitis, and sometimes sterile inflammation can also occur. There can be some systemic side effects to anti-VEGF, MI, stroke, embolization, all these things can occur as well. Now, legal pitfalls, like some drugs are off-label and not approved for intravitreal use. So we are not licensed to fractionate Avastin, etc. So these are some legal pitfalls. And these are images where the patient can very clearly see what is going to happen, so that they should also be explained in simple terms, what the procedure is going to be, so that the patient also knows. So these are some basic steps for anti-VEGF injection, which we keep outside our theater so that the patient knows about this. Thank you very much.
Thank you, Dr. Gopal, for a nice presentation on intravitreal injection tips and tricks. There were a few tips and tricks indeed. So now I request Vineet to initiate the discussion among all the panelists.
Yeah, thank you, ma'am. So we have a couple of questions for all the panelists who joined today. So my first question to Dr. Rajiv is that, so since the pandemic is going to be there and there is a lot of variations which is coming to India, so what are the strategies Shankar Netralaya is following with respect to especially for DME patient?
See, important is the follow-ups have become a bit irregular. We have seen that patients are not coming as regular as we want them to see. I think the most important thing is the flow of the patient. That's what we have been trying to streamline the flow so that they spend minimum time in the hospital. They don't wait for the injection. The moment they are seen, there is a separate flow. Create a separate flow for your patients who need intravitreal injection, getting their OCT evaluation and the same day injection. And definitely our telecounseling that we have done probably about more before lockdown, we started that post-injection. We used to see the day 1 and day 3, then we started seeing only day 1. And now it is telecounseling because based on our audit, we found that usually even just with the telecounseling, how are their symptoms, there seems to be fine. And the important thing is streamline your flow of patients. The journey of a patient in the hospital should be as quick as possible.
Okay. Dr. Vasumati, you would like to add anything here?
Yeah, absolutely. We need to maintain the COVID appropriate behavior in the hospital with adequate sanitization. So and these diabetic patients are already immunocompromised. So it is better to make sure that their waiting time in the hospital is as less as possible. At the same time, they come only when it's absolutely essential.
Just one thing to add, don't treat on WhatsApp OCTs. I think this is something, as Dr. Guru Prasad rightly mentioned many a times, it's not only the macular edema, the stage of DR. So recently I had one patient where edema, they are showing that after injection it is reduced. Because he was my known patient, I told him, you please come to hospital, I'll quickly see you. He came. The stage of retinopathy had progressed from moderate NPDR to PDR, which was missed just looking at a OCT. So I think many times we are tempted just getting like locally patient has got some OCT report and we tend to treat. I think though telemedicine is turned out to be a boon, but always better to have some ophthalmologist see the patient. I think that is something which you should practice.
Yeah.
I have one point to add
Yes.
about
Yes,
the
sir.
COVID times. Thank you, Dr. Rajiv, for acknowledging my comments. Um, about the patient coming for injection, he has a consultation, and if he wants the injection the same day, he is immediately given the injection and he goes. But if he wants to come again on another day, then the patient is given a slip of a pre-printed slip on which is written the name of the injection and the date on which he was examined, and he just has to come and report to the department, the help desk, to get the injection done, and that will be a sort of fast track for him. He doesn't have to wait. He doesn't have to even go to the reception. So that is one thing. Secondly, about the post-injection follow-up, what we follow, I think I've also already shared with Dr. Rajiv Raman in some other webinar, is what I practice called, it is called a SAVE, SAVE,
Yes.
which is the self-assessment of vision every day. And with this, the patient is taught how to check his vision with the other eye closed, non-injected eye closed, and check his vision, maybe a photograph or a family photograph or a God's idol, something like that, which or his dear one's face, if he can see clearly every day. And sometimes our counselor also calls up the patient to ask how he is doing. So with this, I think there's no need for a follow-up even on the first day or third day. The patient directly comes after 4 weeks. Provided the patient is able to understand what SAVE means.
Yes.
Good. Okay, so my next question is to Dr. Vasmati. So there is a trial from the DRCR protocol V, which said that we can observe a patient with central involved macular edema with a good vision. So how do you see, especially in context to Indian scenario, would you still observe a patient with central involved diabetic macular edema with good vision with no anti-VEGF injection?
That has to be taken, the patient has to be considered as a whole. Like, especially I give a lot of importance to the other eye status, the chronicity of diabetes in that patient. I would be more keen to treat a patient who, say, a 35-year-old diabetic, a patient who has had diabetes for 35 years when compared to a patient who has had diabetes for only 2 years, with similar findings. And also the compliance of the patient. Like we know that patients who come from faraway areas, rural areas, and generally patients with poor socioeconomic background, where you expect the compliance to be a big issue, then I will not hesitate to give forward the option of treatment to a patient, even if the vision is 6/6 and there is center involving macular edema. And patient with comorbidities, especially kidney involvement or anything else, then I would, and anemia, I would expect the edema to progress and vision to be compromised, so I would treat. But however, if the patient has a recent history of stroke less than 6 months, then I would consider waiting to avoid an anti-VEGF induced problems, systemic problems.
Thank you, ma'am, for that answer. And now my next question to Dr. Guru Prasad. When do you consider switching in diabetic macular edema, especially? Dr. Guru Prasad, you're muted.
At the follow-up at 4 weeks, if the patient has improved, then I will continue the injections for a little more weeks. But if there's no response at all, even after 8 weeks, then I will switch. Number one is the non-responsiveness. And if there is non-responsiveness due to the OCT biomarkers being in favor of inflammation, then probably I'll switch from an anti-VEGF to Dex implant. And another thing is I always believe that patients with low vision, I will follow protocol T, where I will probably start off with aflibercept if the patient can afford. But let me at this point of time tell that most of our patients are patients who can't even afford an IVTA. This is only for the patients who can afford, what I've told all along. But IVTA is also a good drug. Triamcinolone acetonide is also a good drug, although it works for very little time. The incidence of cataract and glaucoma, cataract, of course, patients are usually elderly and we can somehow manage to convince them. But glaucoma is something that we have to keep in mind, and the incidence of glaucoma also is not that huge. And usually it is after the first injection itself that they will respond, first or second injection that they will respond as a steroid responder. And by then we can probably stop it or manage the glaucoma with topical medications. Yeah.
So my next question to Dr. Gopal, I think the most probably debatable question is giving antibiotics post anti-VEGF injection. So would you recommend antibiotics drops post anti-VEGF injections? So what is your practice?
Yeah, that is a controversial question. We are basically, as far as science is concerned, we know very clearly that there is no need for any antibiotics. Because one, it doesn't serve any purpose, and number two, it may actually increase the resistance of the the flora of the conjunctiva. But when you have an infection which is like 0.01%, or maybe if you are injecting 20,000 patients over 10 years, you will get three or four infections. If this person goes legally, then somebody who is not that scientifically inclined may ask this question: why did you not use antibiotics? So as a defensive strategy, we use very mild antibiotics for this. I am sure that scientifically there is no reason, but for the practical considerations, we just use that.
Yeah, I will just share what we do. We don't give antibiotics, definitely. We stopped it a couple of years back. However, in a select group of patients, one-eyed patients, those who are like, you can make out overall the hygiene is not very good, those patients definitely we give. That nobody stops from giving, but I think just for what you said, the reason we are worried about, we don't want to induce this antibiotic resistance. And we have actually looked into the resistant pattern also, and it is really shocking. Many of the antibiotics, it has now become resistant. So better to avoid, but selected group, as you rightly said, it's a right thing. Besides your technique of injection, just want to add one point which I always pay more attention, because we want these patients to come every month and get injection done. We want them to have a very pleasant experience of injection. I think I give very much importance to putting good topical anesthesia. One painful experience, he will never come back again for your next injection. And DME, we have seen the responses, it's only the compliance which matters a lot. So though you had shown, but just I wanted to emphasize that fact, that make it sure. A simple thing of many times what happens when you are preparing injection, sister has painted, draped and put the speculum, and speculum remains for some time. That's a painful experience for the patient. So usually it's good idea that you yourself put the speculum once everything is ready. Don't keep the speculum on. Again, the wire speculum, thin one, because you want to give the most pleasant experience to this patient. Otherwise, he will never come back to you.
Very correct. Very correct. What happens sometimes is because of the rush.
Yes.
Betadine is painted before the effect of topical anesthetic come in. And then even after putting multiple drops of proparacaine, you will not get the patient comfortable.
Yes.
Yeah, very important point.
Very important.
And
one
the
thing
post-injection also,
yes,
I think we should put a drop, maybe a couple of drops of povidone iodine.
Yes. That's important. Post-injection povidone iodine. And one thing which I not practice now at Shankar Netralaya, but when I was in a private practice at Indore, many times, because these iodine small particles, they cause itching, and they will call in the night time to you, and then you will have a sleepless night. That whether he says that little pain, and now you are worried. So I used to give a tear substitute for 2-3 days. That time there were these unims which had come, so I used to give for 3 days. somehow here we are at Netralaya, that practice is not there, but that is something which helped me there because it washes away this excess of iodine.
How many of the panelists patch the eye versus just send the patient off, or maybe limited patching for half an hour, 1 hour?
Limited patching for 1 hour.
I
Dr.
don't
Guruprasad?
patch. Yeah, I don't patch at all, except for patients who have a subconjunctival hemorrhage which is increasing in size. Sometimes which happens with Dex implant, where we infiltrate. I usually infiltrate the conjunctiva with lignocaine before I actually enter with the 22 gauge needle that carries the Dex implant. Sometimes there is localized subconjunctival hematoma which threatens to increase in size. So I usually put a pressure patch for some time and then remove it after 1 hour. Otherwise, I don't patch.
With Ozurdex, one more thing, thing which I have seen, especially when you are injecting in a vitrectomized eye. So just be sure that your intrascleral is very, very oblique, because I had one patient who was operated, who was given, he came with hypotonous maculopathy. So make it sure, especially the vitrectomized eye, your intrascleral route is longer and it is more oblique.
And with multiple repeated steroid injections, what happens is that the sclera and the conjunctiva will become thinner. And probably there is a little prone, they are a little prone for bleeding, subconjunctival hemorrhage.
Yeah. So I think, again, nothing is a right way. All methods are right. People, like even in Netralaya, everybody practices different. People give in indirect ophthalmoscope, some give directly. I make it sure to give it in a high mag. Because again, one subconjunctival hemorrhage that will piss the patient off, will never come next time. So I tend to avoid any, but still after that also you can develop, but try to avoid causing subconjunctival hemorrhage. Yeah.
One
I think
thing,
the most
Gopal,
important thing. Sorry.
No, I just wanted to tell that I keep changing the quadrant for repeated Dex implants so that there is no thinning.
Yes.
Yeah. Please continue.
Yeah. So I think the most important thing that you have to talk to the patient before, at least in the first couple of interviews that you have with the patient, is about longevity of treatment. That is a very, very important thing. Like there is no after 1 injection, after 2 injections. There's the first year, the second year, the third year. That at least that much we should talk to the patient and then counsel them regarding the need for systemic control, because that will actually reduce the number of injections in the second year.
So my last question to all the panelists and most of the general ophthalmologists who are attending this session have this question is on the loading dose concept. So would you recommend the loading dose, monthly loading dose in a treatment named diabetic macular edema? So I wanted to ask this question for all the panelists. What's your opinion? We'll start with Dr. Rajiv.
Yeah, loading dose is important. I do give loading dose and followed by treat and extend, even in DME. But I switch very early. I don't wait for even second injection. First, if I'm not getting anything, if it is increasing, I'll switch. But yes, it's good idea to give first 3 injections. Yeah.
I would advise loading dose, especially in a DME with a lot of poor OCT biomarkers. I use OCT and OCT angiography a lot in my practice to guide what I tell the patient. And I also do tell the patient that they are in with me for a quite extended period of time, whether they like it or not. And so loading dose is a concept which I have, recently over the past 1 or 2 years, I have introduced, and I do talk to the patients about it. But many times patients, due to economic considerations, don't accept the loading dose. But when they come back, when we do the repeat OCT and then I counsel them again, they understand the importance of another injection and they're usually amenable to that. So we can indirectly introduce a loading dose into our practice, even if the patient directly on the face doesn't accept it. Ultimately, they understand and comply with the treatment.
Yeah.
My loading dose is only for CNVMs. Otherwise, for diabetic macular edema and all other edemas, it is just a couple of injections, and after that, it will be PRN. Yeah.
Okay.
I would want to tell that diabetic macular edema responds much slower than a retinal vein occlusion. In a BRVO with 1 shot, almost in 90% of cases, you will have a completely flat macula, and then you go of PRN from there. Whereas in a diabetic macular edema, in which the thickness is about 500, after the first injection, you may have a reduction to about 400. And with the second injection, it may reduce to somewhere around 320. And then with the third injection. So if you treat a patient with diabetic macular edema when the edema is just about 320 microns, with one shot, he can go back to normal. But generally, when we decide on an initial patient whom we are going to do, probably the thickness is going to be much larger. And so it is a slow process. So that is why 2 or 3 injections may be required. But if in a patient in whom after the first injection itself, macula has gone completely flat,
no need.
I would not be injecting that patient again. I will be moving to PRN.
I agree.
Thank you.
But loading doses are definitely a good concept in diabetic macular edema also, considering the chronicity of the disease. So it is definitely a good practice. And in my experience, giving loading doses, and if the patient agrees to that, it goes a long way in the non-recurrence of edema or reducing the number of injections the patient needs over the next few years.
No, what you're talking about is what you're talking about is the studies that have the way of we should follow ideally.
Yeah.
But the real world is little different. I think we need to look at the patient's
logistics. Not all patients agree to that.
And many times, once you have injected and it has converted from a center involving to a non-center involving.
And that's the time to go ahead and do
additional laser and no need for injection.
A couple of points again on topics which I discussed before. If it is a completely asymptomatic patient with about 350 to 450 microns with visual acuity of 6/6, I will counsel the patient, but I may consider waiting. I will not be very enthusiastic to inject. And if the patient is telling, okay, he is ready because he knows, he read, he understands the problem in diabetic macular edema, then I can inject. But the thing is, in a diabetic macular edema, even if we withhold the injection for 1 or 2 months or 3 months till the vision drops, there's no harm done, unlike in an AMD, in which the vision lost is never regained. So we can actually wait for that. And the second point I want to tell was regarding switch from one injection to the other. I generally wait for maybe couple or maybe 3 injections to actually make the decision of a switch. So that is the other part.
Sure. Thanks for the great thoughts that you have shared. I'm sure it will definitely help our audience who are attending, who are passionate to learn the retina, and some may be already practicing retina. Thanks for sharing all this, your learnings with our audience. So we are signing off. Thank you so much for all the speakers for enlightening us.
Thank you very much.
Thank you.
Thank you, doctors. Thank you, doctors.
Thank you
so much.
Thank you, Dr. Rajiv, Dr. Vasumati, Dr. Gopal.
Thank you.
Thank you all.